Welcome to the Aaron Werner podcast on iCode Media. Today I have a fun conversation with Dave Kading, who started off as my mentor and has become a good friend. We talk a lot about specialty in optometry and being specialists within optometry and what that means and what our visions are. We dabble a little bit into AI as well. Hope you enjoy the conversation. If you do, please share with a friend, subscribe. Let us know your thoughts in the comments, and if you're so inclined, please leave a rating. Also support those who support us. CooperVision and the AOA have partnered in a groundbreaking initiative to change the way optometrists in the U.S. treat children with myopia. The purpose of the Myopia Collective is to rally the profession of optometry and its allies to interrupt the status quo and elevate the new standard of care for children with myopia. Every individual is encouraged to become a member of the collective. By joining, you commit to taking action to help slow the progression of myopia in children. You'll receive updates and information about the collective and its work in the fight against myopia, gain access to educational opportunities and resources offered by the collective, and hear from change agents, the ambassador optometrists selected to serve as advocates for community and policy change that facilitates the mission of the collective. Scan the QR code or click on the link in the show notes to join the collective today. In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, Life Meter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being. So let's see that mug again. That's very geometrical. Is it the same pattern all the way around?
Yeah, pretty well. Right. I like this one because it's got a different kind of thumb touch, right? So.
You have made you have turned something so simple, and I wonder the history of the mug. Like, how old is the first one? It's got to be thousands of years old.
Yeah, what is the history of the mug, right?
A mug, right? But you took it went from my hands holding water, right, to maybe a leaf holding water to quickly I can take mud and put it into a shape of a cup, and that turns into a mug. Maybe the biggest innovation for a mug since the innovation of a mug is the handle. And but you've turned it into a story, which is pretty neat.
Yeah, the brief history of why do I post all these pictures of mugs, and I really don't have nearly the passion for mugs that maybe some people think I have. Is, you and I's generation, we're not posting on social media every other day like maybe we should be. And so it was just one of those things where as I was doing more podcasting and doing things, I'm like, I need to come up with something where I can have some repetition and have, something where it's I always know what I'm doing. And so I started this mug thing on Mondays, and then it's been a way for me to tell story of who I am and background of me. People are like, I didn't know, you were a Christian, or I didn't know you shot guns, or I didn't know, just things that just kind of come out, camping or cabin stuff. And so it's been a way for me to introduce myself to people who don't know me personally, that know me professionally. And so it's just been this kind of thing, and then it's a self-perpetuating problem is then everybody sends me their mugs, right? So I get mugs in the mail all the time, and it's just I have so many mugs now of people that have sent me one. The worst was one person didn't tell me they were sending me a mug, and they didn't put their name on it, and it came in the mail broken in pieces, and I'm like, I don't know who this is from. So I crafted a way to try to take a picture, and my assistant was like, well, if you hold it this way, it still looks like it's not broken, and then we can throw it away. And so we did that, and it's just been this kind of crazy thing. So
Well, it
I
brings
should have
all
started the $100 bill club is what I should have done.
hindsight's 2020. Well, it brings a new meaning to getting mugged.
That's right.
Yes. So if somebody wants to send you a mug, where should we send you a mug?
Just look up my practice, and you can send it to my practice.
Send it to the practice, yes.
So I don't know.
How does your wife feel about all these mugs?
Yeah, I mean, she's okay with it. I only bring so many to the house. I've got a lot at the office. I've got some at my cabin, and I have parted ways with some mugs at some point. But now you kind of just keep the ones you like, and it works out. So it's good.
That's cool. For a while we started doing. We still do the Starbucks has the You Were Here collection.
Yep.
Mostly because we wanted to bring souvenirs back, but we didn't want just stupid souvenirs. And so that kind of became a fun way. Plus, those mugs are good size. You can put ice cream in them. You can have coffee in them. You can make some oatmeal in it. It's as much as I don't like supporting Starbucks, I do like their mug stuff. So
that's true.
Yeah, that's cool.
Yeah.
It's neat. And you were right. I despise posting on social media. So much so that even when I go out to dinner with my daughters, as soon as the food comes, I try to take a bite because they're part of the take a picture of my food generation.
Yeah.
Which I have no rational reason why that bothers me. It just bothers me.
Yeah. Yeah. Well, I mean, we come from the generation where, we went outside and we didn't talk on the phone all that often. It was a big deal. So communication with other people about what you were doing only happened when you were in person.
Yeah.
Right? In the next generation, it's very different. And you got to tell people what you're up to and what you're doing, and if you're not telling them what you did today, you're irrelevant tomorrow.
I wanted nobody to know what I was doing. Could you imagine the trouble you and I would have gotten into if our parents knew and that was recorded for time and all eternity?
I know. It's an interesting transition that we've made, and the relevance of us, because now we're the old guard. Mila Brujic, who most people know and
Yep.
is my second half in optometry. He and I were talking about when we graduated and started speaking, we were looking up to all these people and like how incredible they were doing in their profession and how they were speaking and doing all this incredible things and consulting. And he said to me, he's like, Dave, they were our age. Like we're now at that point, and so we have to find ways to not seem as irrelevant to the things that are happening as those people seemed to us. Is like, okay, so we have to find ways to post mug club pictures and find something to do.
Nice. Yeah, that's I'll give my virtual assistant something else to work on to make me look relevant.
It's a perfect thing. It's the perfect sort of thing to have them help you with. I send my photos, and I'm like, here's what I want to say, and they work through it for me. They help me out.
Well, hopefully she can figure out how to work the AI of making a duplicate Aaron so that he can do all the talking and stuff too. I don't have to be involved.
We're close.
I know we are, and we'll get into that. So this is relevancy, I think, is the topic, because before we hit record, we were talking about the shift that we're trying to figure out within optometry of primary care to specialty. And I think that that's part of the progression of us, similar to us not wanting our parents to know where we were when we were teenagers, riding around on our dirt bikes with baseball cards in the spokes. To our kids wanting everybody to know what they're up to constantly. Right? So there's just a natural shift. And part of that is AI, which you just shared with me you are becoming a master black belt in. Yeah. Do they give you an actual black belt?
Yeah, they haven't said so. I've completed my white belt, my green belt. Today was my orange belt, and I'm not getting any of them in the mail, so I'm not quite sure what's going on.
We'll have to figure that one out. Maybe get the AI little the picture of you with it.
There we go.
Cool. So before we jump into where we're seeing optometry and we debate that a little bit, for those who don't know who Dave Kading is, give them the quick story.
Sure. So I'm a practitioner at heart. I have 3 practices in the greater Seattle area. I practice with my favorite optometrist, who is my bride. We met in optometry school. And I did my residency in cornea contact lenses, so focus in the anterior segment, and that's what my practice has been. And now it's evolved to being a specialty practice. We still do primary care, but much of the clinical care that I do is in the specialty arena of dry eye myopia management and specialty contact lenses. I have a residency that I host, which allows me to have my teaching bone filled a little bit, and I get to really share that aspect of it. I used to bring in students, but now we have a resident, so it's an accredited residency through the optometry schools. And outside of my clinic, I also have the opportunity to host several podcasts, the Myopia podcast and the OI show. The Myopia is a brand that we started a couple of years ago called The Myopia, because we have the Myopia podcast, the Myopia website. We're launching the Myopia Minute and the Myopia newsletter. And then last year we launched the Myopia workshop, and trying to bring implementation. I don't think that we have a problem necessarily in the myopia space of people starting to see that it's an issue, but how do we bring it in and implement it into our practice? So that's really what I'm passionate about on that side. And then I do a ton of consulting in the healthcare sector of optometry plus around innovation in my specialties, but also innovation on some other aspects. And so working with industry is a big part of what I do, and ingrained in that is research. So it's a little about who I am and what we do.
So you stay busy.
Yeah.
You got a couple irons in the fire. And the podcasts, by the way, are fantastic. So great
brother.
listens. I don't think I appreciated that The Myopia was the brand.
Mm-hmm.
I like that.
Yeah, I worked that out with my team quite a bit, and I pushed because I'm like, that just sounds weird. And they're like, yeah, but we're sticking with it. The Myopia.
The Myopia.
So that's the brand.
So there was the Facebook, and then it turned to Facebook. So we'll
That's
see
right.
if it shifts to
I
just
don't think
Myopia.
I can get a handle on myopia.com, though.
Yeah, that might be a tough one to trademark. So let's start there, because I can sense sometimes when I'm sitting in a room and I'm hearing a lecture, whoever the lecturer is, we've got a bunch of good ones on myopia, almost feeling inadequate to do something in the practice because whoever's speaking from the stage, one, has all the equipment and all the toys, which I'm jealous of, but two, just can argue very eloquently and knowledgeably on the difference in concentrations on atropine, if we're going to start there, or the small little nuances of the different ortho-K designs or whatnot. And I can see, and I've felt sitting in the room, and this applies to any specialty within optometry, but we'll just focus myopia, on saying, that's great, but I can't do that because I'm not that person. And so I don't want to fail, and so I don't want to start if I can't get to that level. And so I've always had this mindset that most of these diseases are primary care based, right? That we run the risk of inaction if we make ourselves specialists because they should be primary care. But our discussion was before this was unique because you said, well, no, you think that we all should be primary care doctors with a specialty. And I think that would be kind of fun to explore. So the first question is, how much of a specialist do we need to know before we start dry eye, before we start myopia, before we start managing the diseases that are primary care diseases?
Mm-hmm. Well, one of the criticisms I have of our educational process around specialties is that a lot of the education focuses on end stage and the complication of things. And so very rarely are we seeing any very primary care education around certain disease states like myopia management and dry eye. And so because of that, you'll go to a lecture and you'll hear the 73 tests involving all of the different machines that you can do for dry eye as an example. And then everybody's like, can't do it, right?
Yep.
Because I don't have that machine, or I'm not there to be able to invest in that technology. But where do you start off with? So there's 2 tests that I think everybody needs to do in dry eye, and that's how I educate people. Like, you can diagnose 90% of dry eye with just these 2, and that's it, right? So that's the primary care education that I think we have. And in myopia management, we're also struggling with that, is for everybody to kind of bring things in. We're getting a lot of nebulous talk in our primary care education, but that's the way that education is in eye care, right? I go to a glaucoma talk and I hear about and I'm like, I'm out. I don't want to deal with glaucoma or retina disease, right? So I think that's the problem with our educational system, is that we don't treat primary care education the same way that we treat things, and we're talking about how you need to become an expert in this. And myopia management is a prime example. There's really some basics that I think everybody in primary care practices need to be looking at with how they're going to be managing it, because it is a primary care disease that needs to be managed by everybody.
Yep. I love how you put that. I remember sitting through the last glaucoma dinner I went to, and the surgeon was talking about stents and all the different new latest things he's doing, and nobody asked questions. And the room went quiet. You kind of got that awkward sense. And so I raised my hand. I said, at what IOP level are you going to initiate treatment? And he kind of looked at me, and I said, I've never put a stent in my life, and my guess is California scope will never allow me to. But I do see a lot of 28s, 29s, 30, right, where the nerve looks pretty healthy. Right? At what point do you start, and what do you start with? And as soon as I asked that question, the room jumped in. To your point,
right.
It's what's the basics, what's the early that we see, and when do we treat, and how do we treat?
Yeah. So let me speak to myopia so that I can actually answer the question that I'm trying to throw out there and pose, is at what point do we go from primary care myopia management to more specialty practice? And that's when you've instituted or implemented whatever the treatment is that you feel comfortable with, and the progression is still happening at a level that it should not be. Well, first of all, you need to know at what level should myopia management be progressive, and we've got some easy graphs that show us what that is. Now, the next generation of optometrists, just like we all have OCTs, will have axial length. I was against axial length being something that we should all have until we started putting it into other devices, into our topographers, into our autorefractors, and into a handheld device. There's a device that may be coming out at the end of this year, which is going to be on everybody's cell phone. You can get axial length right from there. So when that innovation catches there, then just like when we all got OCT technology, it took us a while, but we were able to do things a lot more effectively for glaucoma, and we will be a lot more effective in myopia management, because you will detect progression far before you'll see it refractively. And because myopia is a disease of eye stretching, that's where we need to be focusing on it. We should be treating myopia before the child ever has a negative refractive error. We should be able to detect that on all of our 4, 5, 6-year-old patients that we're treating. So in that early stage is where we should be. And where do we need to then consider somebody more advanced? And just like any other treatment, there are advanced myopia treatments, when we call it increasing the myopia dosage. And that's where I change the ortho-K treatment zone. That's where I change or modify the soft multifocal contact lens, or that's when I alter the atropine concentration. And you might say, hey, you know what, I'm going to go in all in with atropine. Well, then you just need to know how to increase your myopia dosage, right? If that's where you're going to be like, hey, I'm going to do this until I can't, and then I'm going to refer it out. And then go for it, right? Treat your patients with low levels of atropine and then increase it. We probably, hopefully, maybe this year or next year, we'll have a prescription medication, which will make us feel more comfortable with that.
Yep.
We keep saying hopefully soon we'll have spectacle lenses in that arena, which actually I think is going to be harder for many of us than something like prescription medications. But we're just going to have to figure out how to bring that into our industry. So myopia management, primary care condition, go for one treatment, start utilizing it on your patients, and if they're progressing faster than they should be, then consider referring it out or consider adding additional treatments to you. But I don't know that you need to be a master or expert at all of it.
Well, that makes sense. And I'm going to go back to glaucoma because I'm very comfortable there. I've got I know. Matt, and I know you don't like it, so we're going to have fun with it. But and it, trying to think through a couple things at once. So binocular vision, we're all really good at referring out, right? Either do it or you don't. And if you don't do it, you know who you're going to send it to, for the most part. Low vision, I think, even better. Right now, we don't see a ton of low vision because most of those patients I found are already in a system and they just don't come into primary care. So binocular vision, I had a really good relationship with one of our binocular vision doctors in San Diego. She didn't like glaucoma. I didn't have the room to do vision therapy and didn't do it, so she sent me all her glaucoma beyond monotherapy. She'd put them on, have monotherapy. The minute that wasn't working, I knew it would come to me. And I didn't think any less of her of it. She just didn't want to deal with it. Where I was more than happy to see it. I was able to send her all my binocular vision patients, and that relationship worked well. What I don't see is that type of I think, permission within optometry right now to say, hey, I can manage up to a certain point, but then good on you for referring. I almost think there's a shame of like, oh, why are you sending it out? You should be able to manage that. You should be able to keep it in-house. And not recognizing that you do this well, maybe you do this okay to a certain point, but then it's beyond your, I don't want to say capabilities, but just beyond your interest, right? Beyond your passion, whatever that right word is.
Yeah, I don't
sense?
think that you have ever felt any ill will towards somebody who's ever referred a patient towards you, right? Like how come they couldn't figure this out? No, it's like, yeah, I'm excited about it. And you've thrown this out there in your community, I know I have, is like, even if you just want a phone call, like, call me up. Like, we can talk about it, and if you want me to see the patient, I'm happy to, but if I can also help keep the patient in your office, we're good to do that. But you don't want to do ortho-K and atropine? Got it. I'll do that. I'll do ortho-K on that patient, and you can do atropine, right? And we'll monitor the progression, or, dry eye or glaucoma or whatever it may be. But you also have to tell people, like, I'm interested in this. You have to say, hey, this is my deal, right? This is my jam. This is what I like to do. Happy to help you if you need. And like, what do you need? Who do you want to see? And not everybody has a specialty, and I can't send to the 60 practitioners that refer to me. I can't send something back to all of them. But if there is somebody and they love glaucoma and somebody calls me up and is like, yeah, you got to go see that person. That's the, she's the one that is a specialist in that area. We just need to be better about that. I think you mentioned it, is that we do that well with ophthalmology, but we don't do it well in optometry. We need to be better.
Why is that? What hurdle do you think, because none of us have a problem referring to ophthalmology. Why do we have a problem referring to each other?
Yeah. Well, one is because I think that we figure that if we can't handle it, then they must need a surgical approach, or they need something that's a little bit more advanced. So we don't have somebody check on a retina to make sure it's okay if we think maybe they're going to need laser, right? So we'll send it over to the ophthalmologist, where in reality the ophthalmologists are monitoring most things, and our optometric colleagues are perfectly comfortable with that. Same with glaucoma, right? Is like, hey, we need to send it to the glaucoma specialist. Maybe they're going to do a surgical approach as opposed to multiple different therapies. And why do we think that? Is because those are the ones that we invite into our society meetings to speak to us about what they're doing, right? We don't invite our optometric colleagues who are specialists in those areas as often, and maybe we should. Maybe we need to be like, hey, when is a good referral to you? And just getting up there and saying, hey, this is a good referral. This is who's referred to me in the past. How they've referred to me is the patient was on monotherapy, and we were able to keep them out of surgery for a while. And, then I co-managed with this person through the surgical approach, and then you manage their refraction, and I'll manage them, their follow-up with their glaucoma care from there. So I think it's just that, we think our ophthalmology colleagues are only able to do surgical approaches, and then they get into their management. Well, surgeons are great at surgery, but they're seeing 40, 50, 60 patients a day, and a lot of them are follow-ups. Well, we maybe can help take some of the weight off of that with our optometric colleagues who specializes in that.
Absolutely. That's two thoughts. One is you can't be what you can't see. So if we're not showing that model, right, and our meetings, society meetings, whatnot, then it's hard to duplicate it. Do you think, and I'm going to rub some people wrong here. Do you think it's the fact that we have an optical and a retail center that also helps to make us hesitate to refer, because we don't want the feeling that they may be moving a patient over and then I'll lose additional sales or whatnot?
Well, I've never felt that about referring to somebody else when I thought the patient truly needed the extra care. That I would really, and I don't think any of our optometric colleagues really feel that way. I think that we think that's the reason why it is, that the legitimate reason is I'm going to lose that patient. Where I really think that has less to do with the reason we're not referring to our optometric colleagues versus them specializing, and we don't think about our optometric colleagues as a specialist in a certain area. For instance, I had a friend who worked at and I'll just be frank on this, who worked at an ophthalmology clinic and took all of the pre-ops, post-ops, and surgical care, and then she went into primary care practice. I never referred a patient to her, and it wasn't because of her optical. It was just because I referred to that referral center, right? And I think that's where our problem lies, is that we need to be thinking, oh, well, now she's in primary care practice, primary care, she's in a private practice, let's send it over to her, and that works out really well when we are able to do that. And I hadn't really thought about it. It's like, why am I not referring to her? But it isn't because of her optical. Because, you think about it this way. After you've referred a patient on, very rarely do you think about that patient. Next year, when they're supposed to come in for their eye exam, you don't remember it. The best thing that you can do as a doctor who's receiving referrals is to send more letters than you should back, right? And you can utilize your virtual scribe for that. You can utilize AI for those letters. Just keep it generic in your draft and then copy it over and put the patient's name in it. And just be like, hey, and I retold the patient to go back to UCU for their comprehensive care. It was a great marketing, right, to do that.
Oh, yeah.
It is to just constantly keep that doctor apprised of what's happening with the patient, because honestly, they forgot about him.
Do you think do you think there's ever a sense of, I'll just say failure, I don't think that's the right word, but if I'm referring to Dave Kading, right, for a myopia consult, and I've done what I can with the patient, you're still progressing, but if I refer to somebody who is same degree, same level, that I'm admitting failure, I'm admitting I didn't do something wrong. Do you think we just aren't good at sending that? Because it's easy to say I'm sending you to a surgeon. I don't do surgery. Right. And as I say this, it's funny because it's easy to say I'm sending you to a VT doc because I don't do VT. But how do I say I'm sending you to Dave who does myopia because I kind of do myopia?
Yeah.
How does that?
Yeah,
you know
the psychology of that, right? It's the humility, and maybe we're the imposter sort of syndrome is like, well, this just isn't working as well as we wanted. Your child is going to progress further, and maybe that's where maybe we need to understand better where multiple treatments come in or advanced dry eye treatments can come up. And I think we're doing a little bit better in dry eye of being like, okay, this person has these other treatments. Like I've received referrals over the years for things like LipiFlow, and then I received IPL and amniotic membranes, and it's like they're becoming more comfortable realizing that at the additional therapy, it's getting beyond my scope. Whereas in those early stages, it's like, hey, I can handle all of this, and now it's getting too big and pushing. So I think over time it can become more comfortable for us, I hope. And I hope we continue to do better. But I would say our profession is better today than maybe when you and I started about referring to each other.
I think so. I think we've
maybe
talked
not for glaucoma. Maybe not for glaucoma, though.
I think we've talked a lot more about it. I hear more of the discussion than I ever did before. I think that's where the younger generations have been a lot more helpful, because our generation and my parents' generation seemed to be a little bit more competitive with each other, and the younger generation is less about who wins and how we all get along together.
Maybe it's because they're posting on social media that they specialize in something.
Or maybe I don't want to give social media credit, but you're probably right. And so because you get a lot of referrals, your primary care practice, but you also get a lot of referrals, so I would also consider you a tertiary referral center. How does a primary doc make the best referral to you? How do they tee up their patients? Let's say, again, we're sending them for myopia. I've tried monotherapy. They're progressing more than I'm comfortable with. I want to send them over to you. What's the best thing that I can do to instill trust in the patient for you, maintain trust in the patient for me, but also tee you up for success with them?
Yeah, well, I think any good referred doctor that's been referred to, it's their job to make sure the patient sees that the referring doctor was very smart in making the decision. It's like, oh, and I always tell them, right, part of what makes me a specialist is that all these other doctors have tried all these other things, and now there's only a couple extra things that I can do to really help. And so it was because of their expertise in trying all the things I would have tried first to get us here is to why we are here. And so it's sending them back. So I think the setting up the patient for success is there's a doctor and saying what it is. There's a doctor who specializes this. This is what they do at their clinic, and the progression and the changes that I'm seeing with you are not responding to the therapy like they should. And this is the doctor who can help figure out what's really going on. I'll send over notes explaining the things that we've already done so that they'll be able to take it from here. And that's what I want to know is I don't need like these long notes that we were taught in school. It's just a quick little, hey, we tried this prescription medication, they went off it. And usually the patient's history is going to help me walk through where to go. So I don't need anything long. And that's what I always say to our doctors is like, they probably aren't even going to read it. So just send something brief, like this is the explanation, this is what I've seen with this patient, this is what we've tried to do. I literally have about 100 pages of a patient's information right here for a patient that's referred to me that I'm going to see on Thursday, and it was because the patient was like, hey, you need to read these 100 pages. And that's a little much, right? I don't need all of that. But we do get that sometimes, and if that's what the doctor feels like I need to read, then we'll go through it. But just a brief, like, hey, we tried this, didn't go well, here's the expectation of the patients, and here's what we're hoping for.
I like that. So you don't want all my chart notes where I just hit send chart notes?
You can send them. I will look through them. You can send them. I will look through them. But if it takes too long and that's a barrier, just a quick little note.
Quick summary. So I like that. If you are someone who specializes in something, and we'll get to the importance of specializing in something, but if you are somebody who's looking for colleague referrals from other ODs, what's the best way to make that information available? Is it going to individual offices? I know you're a fan of social media. Is it, how do you see the best way to get that information out and then to help facilitate the ease of those referrals back to you?
Well, I think it's forming community, right? And, your community can start with one or two or three other people and just cross-referring across two or three. And I would say target people in your region who don't or are not able to do the specialty. And sometimes that's our commercial practicing optometrists who are not able, because of the setting that they're in, to do those specialties, and they could potentially be a referral for you. We're always willing to talk to new doctors, and I really think it's a good idea to, 2 to 4 times a month, just go to coffee with somebody, right? It doesn't have to be anything too extravagant. Maybe start your day an hour later, or take an extra half-hour lunch and go and just meet up with somebody and do a quick little, hey, just want to get to know you. I'm in your area, and just get to know them. And if you ever have a patient in this area, happy to chat with you about it. Is there areas that you specialize in or you like to see? And, glaucoma patient, okay, well, maybe there's a patient next week and I can send over to you. So I think forming those relationships first, and then it can grow from there. And then the next step I think you should consider doing is, especially if you bring in a new innovation or a new technology, to be able to have like a little bit of an open house and invite 5 people in and just say, hey, want to to come in and, see this new machine that we have, here's how I'm using it in the clinic. And if you ever want me to do it on your patient, I'm happy to. Or, we would happy to see the patient for you if you want to refer the patient over to us, whether it's an OCT or, some sort of more technical or more prolonged, or even if it's a treatment type of thing like an IPL or radio frequency, you can do those sort of things. But small, I think we all think really grand, right? We're at a point where we actually have I put on a meeting for about 200 optometrists, but it didn't start off there. So that's not something you have to get to as a referral center. It's just like hanging out with people and getting to know them a little bit. And I think that's the way that you start. I've been doing 20 years of this to get to this point, but it's just those little things. And then somebody said, hey, could you come and speak to, 800 of our colleagues in the greater Seattle area? And I'm like, yeah, sure, Yeah. So those openings start to open as more people start to hear about you, and then your network grows because so-and-so told so-and-so, and now you're speaking at an association meeting. And, any opportunity you have to talk about your specialty at a Rotary meeting or a Lions Club, those sort of things, just get out there and get opportunities, which can cost you clinic time, but it's an investment, and those investments need to take place. Referral centers see that right away, right? If you're not busy seeing patients, one of my mentors who has a very busy referral center in the Midwest, when they bring in a new optometrist or a new surgeon, their clinic days are not busy. And the surgeon said, we actually don't schedule them all throughout the week so that they have a slow schedule. He said, I don't want them to ever have a slow schedule on a patient day. Yep. So we book them to do administrative things, and then on their clinic days, they're super busy. So what is it on those days that can get you out into the community and get to know other people?
Yep, I love that. That's a great practice management pearl, by the way, too, that I like to share with offices that are slow or growing or starting up, that don't. We want to be there 24/7 for patients, when I think the opposite is true. When you create a little bit of scarcity and you time block appropriately, then you've got time to invest in these other worthwhile opportunities to help grow and accelerate your growth.
Emergency visits, you can, always. The doctor just walked in, right?
Yeah. Emergency visits are great, especially on doing Christmas with the in-laws. That's when you hope you get that phone call. So, just kidding, Lindsay. No, this is, I like that. So let's talk about the idea of specialists within optometry. And because I started the conversation, quite frankly, before we went live, where I worry that we're going down the path of too much specialty. And it can create an idea of, well, I'm not a specialist, therefore I'm not going to engage. Right? I haven't invested in all the toys in dry eye or all the nuances of myopia management, so I can't do it because I don't consider myself a specialist. I consider myself a primary care doctor. Your take was really intriguing, and I think that you've made me expand my viewpoint a little bit, because you said you think we should all be, most of us should be primary care doctors with a specialty, which is different than being a specialist.
Yeah, I think that we're getting to a point where the number of individuals who like every aspect of practice exactly the same is dwindling. When people are in school, they tend to be like, hey, I really like kids, or I really like doing vision therapy with pediatrics, or I really this is kind of interesting. So I think we need to peek up on that and take that and say, okay, if you find something to be really interesting, lean into that. And if you go into a group practice, then you're that person who tends to be the one to do that, and you're the subspecialist within that practice. Whereas that person, because it is something they love to do, they're going to be way better at doing it. They're likely going to generate higher revenues of patients, because they're going to higher revenue per patient, because they're encountering that patient and converting them to treatments that the patients are successful with. Whereas if there's three practitioners in the office that do IPL, somebody might be like, well, we got this new machine, you have dry eye here, you need it. Well, maybe that patient didn't need IPL, they needed something else, but that wasn't their specialty.
Yep.
And so it ends up that the patients aren't getting as good of treatments. So as you're leaning into the things that you are really, really liking, you can partner up with people who don't like it. Like my wife does binocular vision and pediatrics, and it is not my specialty. I do not enjoy those areas of eye care, but I'm one of the top referrals into their clinic is because I hear people who have problems and I'm like, man, I think you can be helped. I don't really know what's going on with your eyes, but these people do, and you need to go in and see them. And so you become a better referrer when you realize that there's somebody better than you in another area because you're better than others, because you're reading papers, you're like paying attention.
Yep.
You're the one who's excited to go to a dinner program on this new dry eye drug or glaucoma drug, right? I don't get excited to go to glaucoma drug dinners, right?
Oh, come on now.
So if you do lean into that, get heavy into it, and that isn't to say that you can't really dig deep in all areas of optometry, but my grandfather and your father both went to 4 years of optometry school.
Yep.
And they graduated with the same degree. My grandfather graduated in 1950, and he had 4 years of school, right? So he was able to practice optometry the same way we do, but there's a lot more things that we know, like dry eye, myopia, especially contact lenses, binocular vision, glaucoma, whatever it may be. So lean into that specialty. Do primary care just like you want to, but I think that we can become, subspecialists in some areas. And your machine doesn't make you the specialist, right? You mentioned that. It's like we buy a machine and now we've got a dry eye center of excellence.
But my rep told me. I love that. So let's take your hypothetical practice of 3 doctors, right? And maybe not 3 full-time doctors.
Sure.
It's maybe you're running 2 full-time equivalent, right? So it's a $2 million practice, and you've got 3 docs that rotate through. What percentage of time do you think, and they each have a subspecialty, right? Let's call one of them a dry eye person, one of them a pediatrics, myopia, and one of them the glaucoma. What percentage of time do you suspect that they're each are dedicating towards primary care, and what percentage of time do you suspect they're each dedicating toward their specialty?
Well, it kind of depends on how long they have been in that practice
Yeah.
and the demographics of that practice, right? So, but to the degree of what could they get to, they certainly could get to a 30% of their subspecialty, and easily, because if that practice is 100% primary care, you would think that each of them having done pediatrics within their whole scope, if 2 of them say, I'm not doing pediatrics, now you just clumped in and now you got 30% of that one doctor's time, and they're trading that 30% or 20% across between the practitioners. So when you're doing the things that you love to do, your day goes better, you enjoy it, and it tends to be more effective. And so easily a third of your day could be in that subspecialty in that type of a setting.
Yep. I was hoping you'd say that, because my answer to that question is 20 to 30%, depending on what you're doing. The reason I like that is because I think sometimes in our minds, when I feel like I'm an expert in something or a specialist, that's all I do. Or I hear somebody speak from the stage about dry eye, and we go, man, like that'd be great if I just had 5 days a week of only dry eye people, and which isn't the case in 99% of our primary care clinics.
Right.
Right. And so I think that it's important to remember that while that's our specialty, 70 to 80% of our time is still primary care.
Mm-hmm. Yeah.
And taking care of the routine, right? And which helps to find the cases either for you to manage or for you to refer to your colleagues to manage, or even you managing them at a certain level until you're ready to refer them out. And I think that point gets lost sometimes, which is why I didn't like the idea of specialty, because it created a mindset of this is, I don't do primary care, I do this. Where still primary care is our bread and butter.
Right. No, I agree with you. And, that's one of, I think, the strengths of my residency over some of the other programs that are out there. You go to a school program and, you pretty much are seeing almost all established patients in that subspecialty most of the days that you're in clinic, and they've seen every resident for the last 10 or 15 years. But being in a primary care setting like mine, you're having to find those custom contact lens patients. You're diagnosing that keratoconus out of an eye exam of that patient who's got 2 diopters a cylinder and they've never been able to find a good contact lens, right? So that's where those subspecialists within their own practice, they're like picking up on those things, right? So it can kind of be along the lines of, any patient who has 2 diopters a cylinder or more goes into this doctor because they like doing specialty contact lenses, and they're more likely to need a specialty lens if they've got 2 diopters a cylinder. They may be the spectacle wearers, but they get all the cylinder patients, and that's picked up at a new patient is like, hey, tell me a little bit about your prescription, or do you have dryness of your eyes, or, if you have any family history of any eye disease. And yes, there's a family history of macular degenerate glaucoma, and you're 55 years of age. Okay, you're going to go into this person's primary care practice because they're going to be more likely to catch you in that process. So you start to shift your primary care practice towards the patients you like to see too.
I like that. I think I've liked the word emphasis as opposed to specialist, right? My specialty, because I emphasize in XYZ, and I could be easily persuaded in both. But I've never heard it put as well as you did of, from the beginning of the enrollment in the practice, finding the right doctor that matches up with you, not just the one who's available Tuesday at 4:00 because that's when you want to come in.
Yeah.
Right? But finding the doctor, and that really improves the patient experience from day one.
Yeah.
Hey, tell me a little bit about you. I want you to see Dave because he does X, Y, and Z, or I want you to see, Dave's wife because she does pediatrics, and they're going to love her.
Mm-hmm. Yeah. Yeah, and to make those patients even more successful is that you call in and you ask them a couple of questions, and the front desk team is like, oh, you're in the right place, right? Dr. So-and-so is going to be a perfect doctor for you, right? And you're just like, oh, well, when are they available, right? 'Cause
I want them.
I want them if you think I'm going to be special for them.
Yep,
right?
I can wait a minute. So, cool. I love that. I just saw how long we've been chatting and chatting with you. Time just flies. I want to circle back to what we chatted at the beginning on this AI black belt course, because AI is another one of those areas where I can engage with ChatGPT, but I'm guessing you're going to laugh when I say, that's my engagement with AI. So what do we need to know as old people like me who don't like social media, and this AI thing is now coming to take over? Is it going to take my job away? Do I no longer get to be an optometrist? Is the AI doc gonna take over? What do we need to know about AI?
Yeah. Well, I think that the key component is that with each technological innovation that we make in our careers, the curmudgeons tend to poo-poo it. And unfortunately, you're sounding curmudgeon-y. In how you're saying that. So
I'm speaking for the audience. Let's I'll take the blunt. Yeah. I'm a curmudgeon. Thank you.
So it's really about how do you go to another level of innovation to make things easier and better. And ultimately, if we have better patient outcomes because of what we are doing, then AI wins, right? So there's the end stage, the scariest thing, we go from horses to cars, and now everybody's being chased down in the streets and driven over by all these cars, and we got car crashes and people dying everywhere. You can take it to the extreme, of course, right? But on the other side of things is like, where are we going to be able to find it? And yeah, all of the things about AI that could be, doomsday, the end of the world, sure, right? But the reality is, we're probably going to get those things figured out so we don't have to worry about you losing your job as an optometrist. There's going to always be opportunity for you to be able to personalize the impact that you're utilizing AI for with your patient. Now, there's some pretty cool things that are happening and that we can use the innovation and technology for, but there's still a lot of human interaction that needs to be taking place. That empathy, we're never going to get a robot to empathetically care about us, I think, like that we do for each other or have the relationships with each other. And I think ChatGPT is an incredible place to start. It's one form of AI. You're utilizing AI, and you have been for 15 years in your practice. If you've got an innovation that tells you, red, yellow, or green on your OCT, that is AI, and it's been something that you've had for years, and that's one form, right? Your Alexa, your Netflix, and all of those sort of things are utilizing AI, and we've had them part of our lives for decades, but we just haven't realized what it is. And now we're at a point where we can start, interacting with it personally, and that's where ChatGPT is a great place to go. But utilizing that natural language model, which is where ChatGPT and in Google and Microsoft has some. Those interactions are a good place for us as practitioners to be able to start looking for trends and movements and helping with our marketing. I removed all patient information from a patient's chart and made it very generic, and I uploaded it, and I said, hey, just tell me some information about this person. I asked, give me, it was one of these where I had 100 different papers to put in, and then I just could ask it questions about, have they tried this, or when did this happen to this person? So you have to, that's a step where we can't go necessarily easy, but you can see how in the future, if our Revolution EHR or your Crystal or whatever has all of those features into it, now you can start asking it questions about what just happened, or it's listening in the background while you're doing your case history and saying, hey, they haven't tried this medication because I put in there that that's a medication that I liked, and I can put in all the studies that I've been reading and say, hey, when this starts to happen, hey, maybe suggest this for that patient, and boom, it pops up and it says, hey, if you prescribe this medication, their copay is going to be $10. Let's go with that one, or I have these two preferences. So, or I say, hey, the patient has collarettes when I'm doing, and automatically it knows that I want to write a prescription for a medication. It sends it in, and, here's some patient information as they walk out the door that's automatically been printed at the front. So I don't see how that is going to make replace us. We certainly are going to be able to take pictures and have it say diabetic retinopathy. Those things are going to happen, but it's going to help us get better care for our patients. Where we thought autorefractors were the end of us, right? They're not, right? So that sort of innovation. So there's so much more that we could go into. You and I could talk about it for 2 hours about the innovations that we see for the future. But right now, you need to lean in to how can you use the technology that's already available, like ChatGPT, on a daily basis to have conversations. On just right now on your ChatGPT, there is a feature where you can just have a conversation with it. On your way home from work, you just hit that and be like, hey, I saw this with my patient today. What's the most recent research on that? And, how could I implore that research in my patient case tomorrow? So you're utilizing it as an education tool. I still see that we've got a lot of things to improve upon in our educational process, and AI is already making that better for us.
Yep.
So, okay, I could go on and on and on.
No,
but I'll stop there.
you're good, and I'll try to redeem myself for being. Would you call me a curmudgeon? Yeah.
I love you. And
I know.
You are so not curmudgeon. You're so innovative on your technology. So I'm just giving you a hard time.
Oh, I love it. I will tell you that one of my favorite things to do with ChatGPT is that discussion feature, and but I'll tell on the drive home from work if I've had just that patient you couldn't quite get through to, or a staff member that I couldn't quite get through to, and it felt off. I've yet to do this on conversations with my wife or my kids, but probably could. But I try to keep it professional. But I'll tell them, hey, here's the patient, here's the setup. They're an engineer. They're this old. They're everything I understand from their background, and here's what I'm trying to explain to them, and they're just not quite understanding. Role play with me. And then I get to explore different avenues on where I'm trying to come across what I'm trying to communicate without having to do it with a patient in real life and worrying about failure, because I can fail all the time with a role play on chat.
We do well at that, yeah.
And so
I'll give you two things on chat that'll make things even better, whether you're using Gemini with Google or ChatGPT, or there's a couple others that are out there that I've learned somewhat recently. One is instead of asking it to help you solve this problem, say, here's what I'm dealing with. Tell me the ways you can help me. So you're not saying what you want it to help you with. You're saying, show me the ways. And then it's going to suggest some things that maybe you didn't even think of. And you're like, oh, tell me more about that, right? So it'll give you suggestions that you should be thinking about as a solution, as opposed to the one that you were like, tell me the solution to this problem, right? So that's one thing is, so it's, you explain the obstacle, and then you ask it to tell you options to do things. And that has changed my ChatGPT processing considerably. And then the second one is, as you are asking it for advice, tell it who you want it to be. So say, for instance, you are into some, you're a weightlifter and you have this favorite weightlifter who can set up, so say the name of that person, say, I want you to be this person, tell me how to do the following. So you might say, I want you to be a famous marriage counselor. Here's the problems I'm having in my marriage right now. Tell me how to solve these problems or how to get through to my wife, right? So you tell it not just to be ChatGPT, but you're specifically saying, as if you were this person. And now, I do that with law things in my office, or accounting, as I say. I had something with optometry law recently where I was like, So I said, imagine you are an attorney coming after me and trying to get me in trouble on Washington law. Tell me the laws that I'm potentially violating in this scenario that you might come after me for. And then, it says, oh, we got to be after you. So what are we going to bring up, and all the potentials for it. So ask it to be an expert, and tell it what expert you want it to be. And then the other one is obstacles. Tell me the ways you can help me. Those two things will make a huge difference for people in their prompting.
I like that. That's cool. I've used the telling it to be an expert. Actually, on the podcast I take, because the platform we use will give me a full transcription. So I'll upload the transcription and tell it to be a speech coach, a presentation coach, and tell me everything that I can improve on. The first couple times I did it was very humbling.
That's cool, buddy. I wondered why you were so good at this.
Well, it's ChatGPT has shamed me into not using certain expressions and different things.
Yeah.
But it's
good.
It has been neat to do that, but I haven't heard the obstacle one. That one's pretty cool.
It's been helpful.
I like that. Well, Dave, always a pleasure to chat with you. It's I hate that I've promised some friends that I will keep this under an hour, because Alan, I'm talking about you because you listened to it on the treadmill and you said, Aaron, running longer than an hour, Rich starts, beating me up. So we'll make sure it ends at the hour. But I appreciate you, Dave, making time to come on, and really for being a friend and being a mentor. I still think back to the first time I had the privilege of sharing the stage with you, and was intimidated by, why am I here with Dave? Right, this should just be the Dave show, and they got this young kid on with him. So I appreciate everything that you've done, from being a mentor to becoming a friend. Yeah, it's my pleasure. I'm loving to see all the amazing things that you're doing and how you're crushing it, buddy. Well, we have fun. Yeah. Cool. And we'll put all the links to your socials so they can follow your Mug Mondays, and and the myopia in the show notes. So if you want to engage more with Dave, definitely check out the Myopia podcast and Optometric Insights and the rest of the good stuff he's doing.
Thanks, buddy.